Welcome to this integrated medical laboratory science case study. This case is designed for final year students and integrates clinical chemistry, hematology, and microbiology findings. As we work through the case, focus on correlating laboratory data with the underlying pathophysiology and clinical presentation. Integrated case studies are important in medical laboratory training because laboratory professionals rarely interpret results in isolation. Instead, results must be considered together in order to understand the patient's condition and support clinical decision-making. Case scenario. We are presented with a 54-year-old male patient who arrives at the emergency department with a 3-day history of fever, productive cough, chest pain, and shortness of breath. The patient also reports fatigue, decreased appetite, and dark-colored urine. His past medical history includes type 2 diabetes, hypertension, and chronic alcohol use. On examination, the patient is febrile with a temperature of 39.2 degrees Celsius, tachycardic with a pulse of 115 beats per minute, hypotensive with a blood pressure of 92/58, and hypoxic with oxygen saturation of 88% on room air. He also appears confused and lethargic, which may indicate systemic illness. Based on these findings, clinicians suspect severe community-acquired pneumonia with possible sepsis, and laboratory investigations are requested. Clinical chemistry results. The clinical chemistry results show several abnormalities. Firstly, the patient has hyponatremia with a sodium concentration of 128 millimoles per liter. Hyponatremia is commonly observed in severe infections and pneumonia and may be associated with syndrome of inappropriate antidiuretic hormone secretion, also known as SIADH. Potassium is mildly elevated at 5.4 millimoles per liter, which may suggest renal impairment or cellular breakdown. Bicarbonate is reduced at 16 millimoles per liter, indicating metabolic acidosis. This may be related to poor tissue perfusion and lactic acid accumulation. Both urea and creatinine are significantly elevated, suggesting acute kidney injury. In the context of sepsis, this may be due to decreased renal perfusion or septic shock. The patient also has hyperglycemia, which is common in diabetic patients during severe stress or infection. Liver enzymes, including AST and ALT, are elevated, and bilirubin is also increased, suggesting hepatic stress or hypoperfusion. C-reactive protein is markedly elevated, indicating significant inflammation. Finally, the lactate level is 5.8 millimoles per liter. Elevated lactate is a key marker of tissue hypoxia and is strongly associated with septic shock. Hematology results. The hematology results show several important findings. The white blood cell count is significantly elevated at 22.6 times 10 to the power of 9 per liter, indicating leukocytosis. The neutrophil count is markedly increased, which is typical of a bacterial infection. The hemoglobin level is slightly reduced, which may reflect inflammation, chronic disease, or dilution from fluid resuscitation. Platelet levels are low at 88 times 10 to the power of 9 per liter. Thrombocytopenia in septic patients can indicate platelet consumption or early disseminated intravascular coagulation, also known as DIC. The coagulation profile shows prolonged prothrombin time and activated partial thromboplastin time. These findings further support the possibility of developing coagulopathy. The blood film shows toxic granulation and a left shift in neutrophils. Toxic granulation is commonly seen in severe bacterial infections, while a left shift indicates increased production and release of immature neutrophils from the bone marrow. Microbiology findings. The microbiology findings provide important diagnostic evidence. The sputum gram stain reveals numerous neutrophils and gram-positive lancet-shaped diplococci. This morphology is characteristic of Streptococcus pneumonia, one of the most common causes of community-acquired pneumonia. Blood cultures became positive within 12 hours, indicating bacteremia. The urine antigen test for Streptococcus pneumoniae is also positive, which supports the diagnosis. Viral PCR testing is negative, helping to exclude viral respiratory infections. The sputum culture confirms heavy growth of Streptococcus pneumoniae. The isolate shows an elevated minimum inhibitory concentration for penicillin, suggesting reduced susceptibility and potential antibiotic resistance. Clinical chemistry questions. Students should now evaluate the clinical chemistry findings and answer several key questions. These include interpreting the electrolyte abnormalities, explaining the cause of renal dysfunction, and discussing the significance of elevated lactate levels. Students should also consider the pattern of liver enzyme abnormalities and identify biochemical markers that support a diagnosis of sepsis. Hematology questions. The hematology questions require students to interpret the complete blood count and recognize patterns associated with infection. Students should explain the significance of thrombocytopenia in sepsis and discuss the hematological changes associated with systemic inflammatory responses. The abnormal coagulation results should also be interpreted, with consideration given to complications such as disseminated intravascular coagulation. Microbiology questions. The microbiology section tests the student's ability to identify pathogens and interpret microbiological results. Students must determine the likely causative organism based on the gram stain and antigen tests. They should also discuss why Streptococcus pneumonia is a major cause of community-acquired pneumonia and explain the importance of rapid blood culture detection. Finally, students should consider how antibiotic resistance affects treatment decisions. Integrated critical thinking. In this section, students must integrate findings from all laboratory disciplines. They should provide a complete laboratory-supported diagnosis and explain the pathophysiological mechanisms responsible for the abnormalities observed. Students should also identify key laboratory parameters that must be monitored during treatment and suggest appropriate clinical interventions. In summary, this case represents severe pneumococcal pneumonia complicated by sepsis and multi-organ dysfunction. The laboratory findings demonstrate how results from clinical chemistry, hematology, and microbiology collectively support the diagnosis. For medical laboratory professionals, the ability to interpret results in an integrated manner is essential for supporting clinicians in the diagnosis and management of critically ill patients.